a key research scientist in the Ghana Health Service. He has worked on many projects at Navrongo Health Research Center, and he has extensive experience in designing and implementing community-based survey research projects. He is a recipient of a number of research grants, the WHO TDR training grant, the Rockefeller, ADDRF, Ghana Dutch, etc., which he has successfully executed. He has also consulted for WHO Afro, WHO Geneva, Wellcome Trust, and many others. Dr. Akazili is a member of the International Health Economics Association, IHEA, the Africa Health Economics Association, the Health Economics and Policy Network, HEPNET, and the Ghana Health Economics and Policy Association. Dr. Akazili's research interests include healthcare financing, health insurance, health equity and efficiency, also economic evaluation, general health system strengthening and policy analysis, and UHC. He has published over 50 articles in peer-reviewed journals. So, Dr. Akazili, we can see you clearly. Please, your audience here at the Academy and online. And audience, your speaker. Thank you. Thank you. Thank you. Thank you.
Hello. Thank you very much, Madam Chair. Can you hear me? Thank you very much, Madam Chair, for these kind words. Let me just share my screen. Once again, thank you for the warm introduction. I want to stand on the existing protocol to acknowledge everybody who have come for this symposium. I'm honored to have gotten the chance to present on this very important symposium. So as Madam Chair said, the topic is costing and pricing pandemics, the healthcare cost of COVID-19. Let me be sure whether you can all hear me.
We can hear you.
Great, thank you very much. So, as the first speaker said, this disease outbreaks and disasters can affect countries anytime. And the consequences of such occurrences can highly be catastrophic and can result in chaos, mass casualties and destruction of life, livelihood, and property with devastating long-term social, physical, psychological, environmental, and economic consequences that affect the health populations and strain the capacity of the health system, causing so many sufferings and some deaths and economic losses. The situation can even be worse if health systems are not prepared. Akazili noted in his write-up that the two primary drivers of economic cost for individuals, households, firms, and health facilities and governments can be categorized into two. The panic, the uncertainty related to fear, anxiety, and perception associated with the COVID-19 outbreak, and then the actual or suspected cases and deaths reported. By way of method, this is how I put the paper together. We set two studies the estimated cost of COVID-19 pandemics are published in PubMed, Web of Science, Google Scholar, and Eco Literature. I also searched on Gray Literature, repositories, and contacted subject experts. I searched published and unpublished information using keywords as healthcare, the cost, COVID-19, economic burden, economic impact, developed countries, and also the snowballing approach to get the requisite information to put this paper together. To start with, I want to look at the theory and typology of cost measures. Healthcare costs can be identified into 2 or 3 main forms. We have direct costs, the indirect costs, and intangible costs. And these costs can be elicited from perspective of the general society, patient, or the payee. It can be insurance or the third party paying for the individual. So you can quantify cost by this. It's mostly done by societal perspective. By societal perspective, we are talking about government, which all of us are part. So if you can see the diagram, you will see the picture of what I'm talking about. When we talk of total cost, it can be divided into 3: the direct cost, the indirect cost, the intangible cost. And the direct costs, they look at medical care costs and non-medical costs. Under the medical costs, you look at conventional, outpatient, and inpatient, and alternative. And then the non-medical, you talk about transport and others. With the indirect costs, we talk about productivity lost. When people are down with a disease or pandemic and they are not able to go to work, they lose income. That's an indirect cost. That's an indirect cost. And other intangible things that we cannot own. And these are costs that can be enormous, but sometimes we're not able to measure them. But most of the costs that have been taken care of is the direct and indirect cost. But it's important to note that there's always an intangible cost that can also be enormous and can affect individuals, households. I just explained the various type of costs, just to give you a picture. Is sometimes the insurance people use it to use it to compensate persons when an adverse event happens, like a car accident. The cost elicitation is when we talk of cost, when we talk of measuring cost of a pandemic or a disease, whose perspective are we looking at? It can be perspective of the payee, or the payer, or society, or the patient. But most of the cost is normally from the societal perspective, and that's a wider cost perspective. There are various costing tools, especially when this pandemic broke. And we had the researcher develop tools, the COVID-19 vaccine introduction and deployment costing tools, and resource templates, and WHO Choice. WHO Choice is a costing tool that was developed in 1998 when the WHO was restructuring. And it's a common tool that many of the studies have used to estimate the cost of diseases and also this COVID-19 pandemic. The question is, how much does the pandemic cost? The World Organization for Animal Health published a study analyzing a Asian influenza outbreak in South America, and in 2007, which quantified direct costs and losses as well as indirect impacts, including the ripple, spillover, and wider societal impact. 70% of the overall cost was attributed to indirect costs, but fully attributable to the underlying contagions. The diffusion and lack of time, that's normally between 1 or 2 years, makes costing sometimes very difficult, especially with regards to pandemics. During the World War I, the Spanish flu, that's 1918 to 1920. The sheer lack of data are factors that explain the political complexity in measuring the cost. So these are factors that make costing sometimes very difficult to measure. Time lag, and also the political complexity, and even getting the right data to measure the cost sometimes becomes a problem. I'm just showing you this diagram to illustrate the breakdown of the broad categories of cost, the direct cost and indirect cost. You can see the elements or the components of direct cost are controlled measures, deaths from disease. But the indirect cost, you look at low productivity, consequential on farm loss, ripple effects on reduced demand, complementary products, and even spillover effects in other sectors like tourism, transport, retail. As the first speaker said, during that the pandemic, for instance, people could not come out to do their normal business, especially those in the informal sector. These are all costs that are indirect, but are enormous and affects households and individuals. I just want to give you a summary of past pandemics. It wasn't only this pandemic, but we have had past pandemics. And we can talk about the Spanish flu that happened 1918 to 20. It was global. It affected 500 million people with 50 million deaths. That's about 10%. Asian flu, that's 1957, 1958. It was global, about the same number of infections, but this time 2 million, and that's 0.4% of the population that was affected. You can talk about the SARS, 2002, 2003, that was specific, that's SARS in China. You can talk about swine flu, 2009, 2010, global, of 6.7 million cases, out of which 20,000 died. Ebola, recently, mainly in West Africa. MERS, 2012, 2017, mainly Middle East. So these are past pandemic that we can take note of. And these were the infections and the fatalities. But let's look at the cost. They came with their cost. From Spanish flu of about $5 billion US, rising up to the MERS, which at about Ebola, which gave about over $50 billion. And you can see these are not, these are huge losses that could have gone to productive ventures. But the pandemic has swallowed up this money, this cost. This is very, very huge. The rest of the paper will be the following. I will look at the pandemic, zeroing down on COVID-19 globally. I'll zero down on the developed countries. I'll go to low and middle income countries, situation in sub-Saharan Africa, and I'll come to Ghana. But they will be very brief. On global level, healthcare costs push more than 500 million people into extreme poverty. And COVID-19 added to this burden, halting progress towards universal health coverage. You all know countries are moving out. The SDG is rolling out a program of universal health care coverage. And we are all working towards the universal health coverage. And this pandemic has rolled back these gains by the burden, the sheer burden, and the cost that it has inflicted on countries, individuals, and households. Health systems around the world have been overwhelmed by COVID-19, causing disruption to other vital services. Like the first speaker said, because of COVID-19, people were not able to access other services. We are reluctant to go to the facility because of fear of contacting some other disease, contacting COVID-19. And so other diseases were suffering. People who were supposed to access immunization, for instance, dropped in other countries. Other healthcare, like antenatal and other primary healthcare, which are essential, also suffered due to COVID-19. Even before the start of the health crisis in early 2020, almost 1 billion people were spending more than 10% of the household budget on health, a situation which is undoubtedly worsened by the pandemic. According to World Bank, if you spend more than 10% of your budget on healthcare, then you are running into a catastrophic payment. And the pandemic aggravated this situation. It brought a lot of people into this bracket of people spending or households spending more than 10% of their budget on healthcare. The situation affected a lot, especially in sub-Saharan African countries. We all know that COVID-19 has killed an estimated 50 million, according to some literature. And on top of the human cost, the financial impact of the COVID-19 pandemic has been huge. The pandemic and its measures implemented to control the disease have impacted populations all over the world and exposed inequities, vulnerabilities, and fragilities across the globe. The impact cast across the health, social, and economic well-being through disruption to economic opportunities and livelihood and changes to work-related health and safety. The toll of the pandemic has exerted on the global economy has been significant, with the International Monetary Fund, IMF, estimating that median global GDP dropped by 3.9% from 2019 to 2020, making it the worst economic downturn since the Great Depression. The IMF also estimates the pandemic will cost the global economy 28 trillion in lost output by 2025. Aside the direct financial outlays, the cost associated with the pandemic includes opportunity costs. And this cost is so huge and it's a component of indirect costs. And it affects not only individuals and firms, but governments and hospitals and schools. The pandemic has brought about changes in the labor market situations in ways that expose vulnerable populations to even more precarious and risk to livelihood. These costs are not often immediately thought about. Like the speaker said, people who could not go out to sell, people were locked up, and because of the nature of their work, they cannot work from home, had a lot of their livelihood disrupted. And those costs are not quantified, are not always thought about. What we are always costing is what government has spent, what firms has lost, but those costs that are in the informal sector are not always thought about. So we look at it from the developed world. The United States of America accounts for 25% of global deaths, 41% of the mortality cost. In China, using retrospective data records from COVID-19 patients, the mean direct cost of treating a COVID-19 patient from a health system perspective was estimated at over almost $7,000, which means a total clinical management cost of COVID-19 in China was almost $500 million as of March 2020. The cost of drug acquisition was highest, accounting for 45% of overall cost. So most of the cost estimates, the drugs cost was so high. The total cost of hospital admission related to COVID-19 was estimated at more than $317 million from January to November in Canada, and that's excluding Quebec. Another study revealed that the socio-economic burden of COVID-19 in Russia Federation amounted to 4.3 trillion rupees. That's 71.1 billion. And that's 4%, equivalent to 4% of the GDP. Overall cost for the health system for the first few months during the pandemic in Germany was at least 16 billion, with treatment costs ranging from 900 euro to 53,000 euro per patient, depending on the major diagnosis categories and the clinical severity of the pandemic. Still in developed countries, Netherlands was not spared. It also had to spend over nearly $500 million in 2020 and 477 million in 2019 and 380 million in 2020. That is very huge. The estimate included the direct medical costs in hospitals and other indirect costs. When in Australia too, they spent 291 billion in direct economic support. Spain reports that the total direct medical cost of 9.4 billion by the end of June 2020. And this corresponded to 12.3% of total public health expenditure in Spain. And the cost figure is considerably higher than the spending on diabetes or cancer. In UK, the national audit estimates that around 55 billion of the 84 billion budgeted for health was spent on the COVID-19. And this is the breakdown for UK. They had the breakdown of the cost of the pandemic on the economy. You can see the major breakdown. The business was 104, other public service 60, individuals 36, health and healthcare was 55. So these were the economic burden or the total spending on COVID, and that is very huge. Let's move to the developing countries. And as IMF, World Bank indicated, the burden was, even though developing countries were spending less, but as a percentage of their GDP, they had a huge burden on their economies and their populations, and brought a lot of cost to low economic activities meant low revenues. And so it affected their taxes and fees directly or indirectly. Cost of clinical management was estimated at 43 to 75 per capita in 76 developing countries, according to Torres, Ruda, and others. Cost per case treated range from 282.9 to 1,124.24 for severe cases, and from 3,000 to 14,000 for critical cases. And that is assuming 8 days of hospitalization for severe cases and 10 days for critical cases. These are the costs that were estimated. The clinical management cost of COVID-19 greatly varied among the developing countries, and it ranges from 0.1 to 12% of GDP, and as low as 0.4 to 223% of total annual expenditure, excluding out-of-pocket payments. And that out-of-pocket payment is the individual, so it excludes that. Still, in developing countries, we recognize that households and individuals even were not able to access treatment because some of it, even though when you are diagnosed with COVID-19, government takes responsibility, but transport costs and other costs that are not normally measured bar households and families from accessing services. And that is one of the effects of COVID-19 and its cost component that are so wide, but normally it's always narrow, that government cost is normally what is put out there. In sub-Saharan African countries, the cost is not so different, but from a health system perspective, the World Bank estimates an average of 3.6 treatment costs for a mild case to 15 points for a severe hospitalized case. But in Ethiopia, it was higher, 147 per day for home-based treatment to 108 per day for severely ill patients. A study in Kenya, however, found that the estimated cost of treating COVID-19 ranged from 278 for mildly ill patient at home to 5,879 for a critically ill patient managed in a resource-intense hospital settings, like University of Ghana Medical Center. Let's come home to Ghana. And I want you to look at this graph and keep that in memory whilst we'll go on. You see Ghana, our domestic general government health expenditure as a share of gross domestic product in Ghana started dropping 2008, 2019. It started dropping 2010, and you can see the drop down there. It has implication for financing healthcare. It's how much is spent on healthcare as a percentage of our gross domestic product. In Ghana, the initial phase of the pandemic was met with increased concentration on response planning, as the first speaker said, and preparation by adopting WHO guidelines. The approach prioritized government procurement and distribution of PPEs, setting up isolation centers, limiting travels into the country. Upon recording the first case in Ghana on the 12th of March, aggressive contact tracing was embarked on, and the 3 T's, test, treat, and trace approach was implemented in Ghana. This approach involved aggressive surveillance and contact tracing, testing, and clinical case management of infected persons in health facilities. The number of laboratory testing sites were increased, a COVID-19 tracker mobile application was launched, and medical drones were deployed to facilitate the rapid transport of samples for testing. About 45,107 additional health workers were engaged, 1,000 of them designated as contact tracers. Also, an increase of 50% salary was provided to all frontline health workers as incentives. Ghana efforts were thus touted, as the first speaker said, as among the best COVID-19 measures to be implemented by a developing country in Global South. But government lost over 5 billion in oil revenue as a result of the 2/3 decline in crude oil prices due to COVID-19, because people are not traveling. Non-oil revenue were expected to fall by 2.25 billion due to the slowdown in economic growth. Government also faced significant unforeseen costs associated with the COVID-19 response, National Preparedness and Response Program, 572 million cedis. COVID-19 alleviation program, that's 1.2 billion cedis. 600 million in the form of soft loans to small and medium enterprises. 320 million to supplement healthcare workers' income, and 280 million for household water supplies, food packages, and public grain procurement from smallholders. That's what government had to spend. The First Speaker mentioned the free water. There's nothing which is free. We had to pay for it from what we took as a loan from the World Bank. Available data on the COVID-19 in Ghana are desperate, but not so much. It's done by Navrongo, Asamane, Dohene. These were the few authors who have worked on COVID-19, especially on the impact, on the cost of implementation, and then in Ghana. These are the few authors. And these studies are conducted in retrospective, prospective, modeling designs of COVID-19 interventions. These existing studies generated data sets using researcher-developed tools, COVID-19 vaccine introduction and deployment costing tools, and resource use templates. These were the tools that were used in their studies. As I said, limited studies have been done in relation to cost. And these studies estimated the cost to COVID-19 vaccinations of Navrongo, the University of Ghana School of Public Health, and together with the Health Technology Assessment Team, did a study on COVID-19 vaccinations, the cost related to COVID-19 vaccinations. And then Asamane also did some work on health workforce investments in Ghana. Prof. Navrongo estimated the total cost of COVID-19 vaccinations ranging from $348.7 and $436.1 million for a population size of 17.5 million Ghanaians using the COVID-19 vaccination introduction and deployment tool, as I said earlier. Asamane and others found that the cost of healthcare workforce investment highlighted that Ghana spent at least $213.6 million on health workforce investment to fight the pandemic. The cost estimate excluded wage taxes, market premium payment, and other risk allowances. Again, the authors reported that the costing estimate carried out in the study excluded PPE, case management training for health workers in Ghana. Hamza Ismaila also estimated the cost of pandemic by disease severity in Ghana, and the results are summarized in the next two slides. As the table clearly shows, they indicated the inpatient costs, cost of home management. Of course, when there's an inpatient cost, there shouldn't be any cost in regards to home management. But if there's inpatient cost, and if it's a mild case, the cost was $1,259. If it's a moderate, $1,269. If it's severe, $3,500. And if it's critical, it went to $4,589. And this is in US dollars. These are the various costs. Investigations cost also is shown there. And from home management is 132 to critically ill investigations is 489. For medications, if it's home, it's $14. It goes up to $335 when it's critical. Overhead, $17, and it moves on to about $14,660 when it's critical. Staff time, $118 when it's home management, to about $3,312 to when it's critical. So you can see the total is $282 to $23,382. In terms of the percentage, with home management, the cost drivers are the investigations and staff time, if you look at it. When it's mild, the cost driver, the major cost driver is the overheads. When it's moderate, the cost driver is the overheads. And same applies to what is severe and then critical. This slide just to show you the cost-benefit analysis of reducing future pandemics. The US National Academy of Medicine estimates that committing an incremental $4.5 billion annually to be used primarily for strengthening national public health systems, funding research and development, financing global coordination and contingency efforts would significantly reduce the severity of future pandemics. And in fact, it says that the economic loss will gain 50 billion if we take measures and put our house in order globally. That's what the Academy estimates. World Bank and the WHO also estimated that a little as $1 to $2 per capita per year spent on pandemic preparedness would allow for adequate preparedness. So investing in preparedness also yields a significant financial benefits. An annual investment between 1.9 to 3.4 billion to strengthen animal and human health systems will yield an estimated global public benefit of more than 30 billion. That's not a bad idea, or that's not a bad return. And that's the looking at the cost-benefit analysis. Prepare and the benefit will be so huge. But if you don't prepare, the opportunity cost is so high. So what's my conclusion? The cost burden of COVID-19 goes beyond the health system, as it has impacted on several aspects of social society and the economy and the structure of the populations around the world. The COVID-19 pandemic has multiplied impacts on health worker force, including infections and mortality, violence and harassment, discrimination, burnout, and mental disorders, as the speaker illustrated. The economic shock imposed by pandemic and the resultant response measures adopted by countries also constrain both the public and private sector's ability to mobilize resources to expand fiscal and financial space to recruit newly trained workers. According to Viscosi, the total global mortality cost associated with COVID-19 as of July 2020 alone is $3.3 trillion US. The economic losses caused by the pandemic are at par with other high-profile economic threats like climate change, which is between 0.2 to 2.0 of global GDP at risk, or large-scale natural disasters, which is between 0.0 to 0.5 of global GDP at risk. All three are qualified as major economic disasters by the IMF, with 0.5 or more of global GDP at risk. In other words, if a risk is more than up to 0.5, it's a GDP at risk. However, while natural disasters, and in particular climate change, are declared frontline issues, attracting both political attention and significant funding, pandemics risk is not. So what is the way forward and recommendation? The way forward is to improve on health emergency preparedness worldwide, but this will require substantial and sustained increases in investment. It will require over 1.6 billion per year to improve capacities across 139 low and middle income countries, because they are the harder hit and their health systems are weak, to 43 billion per year to support national level activities worldwide and implement global level initiatives, such as research and development for health technologies. diagnostics, therapeutics, and vaccines. Substantial investment in health system reforms and strengthening are significantly required. African governments with their development partners need to implement strategies to make health systems more resilient and responsive. And this is very urgent, and heads of states must commit and invest, because this is the only way out. All countries must build strong systems. For instance, 3 days ago, there was a seminar, a roundtable seminar on the state of the nation health at the University of Ghana, Legon, the School of Public Health. And this point cannot be overemphasized, that we need a national, to institute national health accounts that will take care, that will be able to measure in comparative way health expenditure and tracking health expenditure as useful accounting tools for planning and budgets. Even health preparedness was also echoed in that seminar. We must prepare for the worst. Financial institutions must link preparedness with financial risk planning. And development assistance funders must create incentives and increase funding for preparedness, as I said earlier. And the United Nations must strengthen coordination mechanism, because this is very, very key. And so indeed, COVID-19 has taught us some lessons. It has made us aware of the global interconnectedness that we are as a people in the world, and the fact that a disease does not have any nationality. This is very key, and it's a lesson that the recent pandemic has taught us, and that we need to work together. Look at what happened. It started in China, and less than 3-4 months, it was all over the world. And that's why we are together, and we're in a globe, and there's no country which is an island. And we need to work together, prepare for future pandemics. So this is a take-home message. And this is the end of my presentation. I thank you very much for listening to me. I cannot leave you without suggested research areas. In my review, I realized that all these pandemics or all these studies there was some gaps in the studies. And I am suggesting that the cost of COVID-19 to households is an interesting area that can be looked at. But we might be mindful of the issue of recall bias because of the time lag. And the catastrophic and impoverishment effect of COVID-19 are topics that we can look at. Thank you very much. And these are my references. Thank you.
Well, audience, I think we can do better. Another round of applause. We have been treated tonight to 2 excellent talks. The first by Dr. Amachu Edwin, Let No One Be Left Behind, and the mitigating the socioeconomic impacts of COVID-19. Impacts on mental health. I think that was my take-home message, mental health. And then the second speaker, Dr. James Akazili, the costs. And if we don't prepare, we really are in for trouble. We've got to sit down and prepare and work together. So we're going to open this up for about 10 minutes interaction, I think, mostly. Let's see. Yes. So we'll start. You identify yourself and the question, and we do 5 at a time. And you just say which of the talks, talk number 1 or topic number 1 or topic number 2. We'll do it in 5 batches of questions, and then we'll see how we go. Thank you.
Again, thank you both for excellent lectures. My name is Jumwa Ejo. I'm a physician and a fellow of the Ghana Academy. Dr. Edwin, thank you for an excellent talk covering the socio-economic impacts of COVID-19 infection. You did touch on some of the psychological, psychiatric consequences of COVID-19 infection. In your experience and in your reading, did you come across the syndrome where people have had longer-term psychiatric developments after COVID? It seems to be quite widely recognized in Europe and North America, but I haven't seen very much about it in Ghana. So I'd be grateful if you could shed some light on that. Thank you.
We're doing any more questions, please?
My name is Animli Aaron from Accra Academy. Please, my question goes to Dr. Ama. With the socio-economic effect of the COVID-19, coupled with the high cost of living, most parents have little time for their children. I mean, they are busy with workload and others due to the economic situation. So what is the mental effect or the psychological effect of this on their children? Yes, please. So that's my question.
Three more. Presec, I'm sure you listened attentively. Have any questions?
So I'm Frank Archer, a student of Presec Legon, and I want to know roughly how the mortality cost was calculated for the COVID-19 period. For the period. Yes, please. Just roughly, please.
Okay.
Thank you.
We'll have Dr. Ama. You can do that for us. The mortality. Oh, Akazili. About the cost. How was the cost was calculated? So, Dr. Akazili. Okay. 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 Good. One more.
This question goes to Dr. James. Please, I would like to know the cost analysis of the post-COVID effect on households in Ghana. Yes, thank you.
And the last one. I think we can address the four and while others are still formulating the questions. Thank you.
Very much for the questions. Yes, Dr. Edu, I actually, in the paper I submitted to the Academy, I actually had a session on long COVID, but in my presentation, I left it out. Yes, it is. And, you know, the thing with long COVID is, I remember when it started coming up and then data started trickling in, and it looked like we were not getting any in Ghana. But there's this, I've forgotten the title of the study, but Ghana was part of a group of countries that were supposed to be providing updates on COVID and usually after the effect. So for UGMC, for instance, there was a post-COVID clinic we started running. And then we realized that per the criteria of people who have recovered clinically, but they still have several issues, and a lot of them are mental health, but then there was also physical thing. We were picking that up even in Ghana. So it's not that it's just outside, but we also have it here. Because of the presentations, if you're a clinician and the patient comes to see you and complains of lethargy, difficulty working, easy fatigability, you suppose, unless you have a history of COVID, you're going to look for other things. And if you look at the signs and symptoms, it can actually cover a lot of conditions. So the diagnosis of COVID then becomes critical in being able to pick up that it's long COVID. Unfortunately, most of the treatment centers that were doing the post-COVID clinics for their patients stopped over a time because, I mean, for most people, they will recover without any sequelae. So I hope that we don't lose it because we stop there. But it's a real thing that happens, and in Ghana too it does. Most of the manifestation are psychological, but you do have the physical aspects too, so we have it. And the young man, yes, you are right. Remember I talked about the fact that during the COVID, when I was working, my son made a comment that even daddy is at home, so why are you? And I was working 7 days for most times, because there are days that you don't plan to go to work, but you get a call, there's an emergency, a patient is having a difficult time, or sometimes it's the people, the health workers who are looking after the patients. You need to have a debriefing session with them, because if you don't do that and they carry the burdens, and especially when you don't expect some people to die and it happened, it can really be a challenging thing. It's not easy being a parent. You want to be there. Most parents want to be there for their children, but it's also important that you understand that if your father stayed home all the time, you'd be worried. You would ask, why are you home? Why aren't you going to work? I mean, there are days that maybe you because in your expectation, the parent goes to work, comes home. What is happening now is that because of the economic crisis, people are struggling to make ends meet. So maybe before, your parent had a regular job or her regular job that she did and would come home and you see them. But things have gone up. I don't know whether anybody's salary has gone up. So to make ends meet, they are also trying their best. But you do have a point. If you do neglect the child, there are consequences for the child. Mental health issue. The first one is insecurity. You begin to doubt, is my parents' job more important than me? And I can give you an illustration that brought this home. There was this young boy who once asked his mom, "Mom, why do you always lock your bedroom door when you are going to work?" Then he said, "Oh, I want to make sure that the help doesn't pick anything from there." And the boy said, "But you leave me with the help. Does it mean that what you have in your room is more important than me?" And this was a young child, and it shook the mother. I'm telling you something a parent told me that he hadn't thought about it. You lock your bedroom, maybe you have jewelry, you have money, you have clothes. But your son, your daughter, the person you don't want to go to your bedroom because they might steal, you've left. So it can make the person begin to question who they are, whether their parent cares or it's all about money. And it also creates an opportunity to be easily influenced, because children need acceptance. They need to know that they matter, that their parents care for them. And if, because your parent is working all the time and they haven't had a conversation with you saying, "Kwame, Ajua, I know that things have changed. You remember before I used to come home, we'll spend time with you, go over your homework, but now it looks like you don't see me." It's not going to be like that. But because things are hard. If I don't work extra, I might not even be able to pay your school fees. So going away is explained to you, and even when they are away, maybe call, test, and when they come, the little time they have, they make sure that you know that you matter. That can mitigate that. So it's not always the choice of a parent, in quotes, to do that and leave their children, but the communication is key. So the impact on the children is real. You get into bad company, someone makes you feel special, you get into gangs, and in these days, online people influence you, all of that. And unfortunately, if the child gets into this, the very money that the parent is working for is what they will also use to. But just know that if a parent is working too much, it's not because you don't matter, but they are doing their best to be able to provide for you. Thank you.
Okay. Dr. Akazili, you can take there was one on costs, mortality costs, calculation of cost of mortality for COVID-19. Mm-hmm. You understood that?
Yes. Yes, I got two questions, but the second one I didn't hear it well. I had costs, and then I had households. So the cost was the second question was like the suggested research area I suggested by last slide. But the first question is cost of mortality or COVID-19. It's a complex calculation, and there are various methods of doing it. But one way, and I want to break it down for you to understand, is to look at DALI, DALI, disability life years of life lost. Okay, so taking years of life lost, we have what we call expected life expectancy between male and female, and then you can. So when somebody unfortunately dies at a certain age, we can express it. You can look at that age and see the current life expectancy. You could then subtract that the person has lived for instance, 50 years, and the life expectancy is about 65. So the person would have had 15 years of productive life. If the person is working, the person will retire at age 60. So at age 60, the person will retire. So the person has 10 years working life. After that, the person has 5 years, still can earn income. So that is now calculated as the loss of the individual who would have been productive in society if he hadn't died, unfortunately. So you see, a younger person death has more weight or cost than an older person. Is it clear? The questioner.
Yes, you can go on to the second one, please.
In male and female, because our life expectancies are different. With regards to the costs, the second question, I said I didn't hear it well. If the person can repeat that question. I had cost and I had household, but in between, I didn't get that.
Okay. The young man, yes. It's a cost of health in the household, is it? Mm-hmm. Did you hear that? Cost analysis of post-COVID on the household.
Which can be looked at.
Sorry, you're muted. We're not hearing you. You're muted. He's muted. You're muted. We can't hear you.
Oh, sorry. Okay, so let me repeat the whole thing. The cost of mortality
please
cost.
Repeat. Start from the beginning.
Cost, that there are several ways of measuring it, and one way that I would like to use to let the young man understand is years of life lost. There's also what we call DALIs, there's QALIs, these are economic terms. But one simple measure is a way of measuring is years of life lost. To the extent that in every country there's a life expectancy. In Ghana, I'm sure we are about, the last time it's about 65, or something like that for male, this 66 for female, and then 64 for male. Female live longer than men, male. So if it is 66, for instance, and somebody dies at 55, we know the person still had, and a normal cells, holding other things constant, the person will still have about 11 years to live. I'm not saying that the person is going to die 66, no, but that is the life expectancy. You have to use that to calculate. Okay, so with that, the person has 5 years productive life because we retire at age 60. But after age 60, people are still also productive. So you use that to do the calculation of that individual and then come out with the cost of losing that person. So that's one measure or one way of working out or calculating the cost of individual. All right. So you can see with that, you can see a younger person dying has more cost implication than an older person dying. That's holding other things constant. Because somebody can argue that what if a person is not a jobless or is not as in school and a whole lot, but just holding other things constant, that is the younger you are, the younger mortality has more cost implication. Then of post-COVID, I think we are still in the COVID, and that's an interesting suggested research area, which I welcome it. And I think when we are declared over, we will definitely be looking at that. But one thing is, sometimes when it keeps long, then a recall bias. In other words, people forget, and they have to remember to give figures. And you don't, sometimes it's not, you can only make estimates. So but it's an interesting area to look at. And because of the traumatic nature of COVID-19, people will remember the issues or what they have gone through in terms of the direct cost, the indirect cost, and possibly intangible costs that we can look at. So that's an interesting area, but it can be looked at. You only need to approach households, try to help them to recall and estimate what the cost is to households. You can even do for individuals. Yeah, thank you very much.
Thank you very much. I think time is fast spent, so I will take the chair's prerogative. Oh, okay. There's one online. May we have that question and address it to one of our speakers?
Okay. Good evening. So, Professor Elsie Ifakofman has a question. Okay, for the second presenter, are there any cost estimates associated with the disposal of huge volumes of PPEs? Okay.
Cost. Okay.
Did you got that?
Did you get the question? Please
okay,
unmute.
Let me repeat.
Dr. Akazili, please unmute.
I didn't come across a study like that.
Oh, the question again, please.
Okay. So he said, for the second presenter, are there any cost estimates associated with the disposal of huge volumes of PPEs?
You got that, the disposal of huge PPEs, the cost.
Yes, I got a question.
Okay.
My answer is, I didn't come across a study like that, but it will be an interesting area to look at.
Okay. Any other? Any other?
Okay, so this is from Prof. Amos La. He said, thanks to Dr. Akazili and Dr. Edwin for treating us to such informative talks. If I may, could Dr. Akazili throw a little more light on the cost of not costing for current but also anticipated pandemics? Yeah.
Yes.
Please, you get that?
Cost of not costing.
Yeah. Costing for current but also anticipated pandemics.
Yes. Thank you very much for the question. I indicated that in the slide that I talked about on the cost-benefit analysis, where I indicated that $1.2 to $3 per capita was indicated by WHO and World Bank that if we set that aside and prepare, take our emergency preparedness seriously, then we could be strengthening our health systems, making them more resilient, and preparing ourselves to combat future pandemics and making them less expensive. But most of the times, as human nature, when the pandemic is over, we wash our hands and then we go back to business as usual. I went to Sierra Leone and did some work, and when they had Ebola, they had hand washing vertical buckets, and they were washing their hands in various public buildings and other public gatherings, and they were observing all kinds of things. So when the pandemic, COVID-19 pandemic struck, it was easy because we were preparing, or they had just come out of the Ebola and they were still practicing that. So the effect was less. So what that means is that preparedness is very important. Emergency preparedness is very key. But sometimes countries have a lot of demands, a lot of activities to undertake, and so they cannot set money aside and wait for a pandemic when there are other pressing needs. That is the key, that is the problem. And that's why partners, WHO, World Bank, and other bodies are called upon to look at this emergency preparedness seriously. And those who can help, so help and set up preparedness. It could be one, we can zone African countries if individual countries cannot prepare adequately. We can zone the countries and to put them into groups and make preparations so that when the pandemic strikes, we activate our emergency preparedness and deal with the issues before they get out of hand.
Thank you. Thank you very much. I think we should give both speakers a round of applause. Now, I will not attempt to summarize these wonderful talks, but a few take-home messages. The first speaker, Dr. Edwin, gave us a background of the early years of COVID, when we wouldn't even leave our homes because if we step out of doors, we thought we'll die. And she illustrated this and the acute stress at the best university health center in the country. I mean, and especially when you weren't set up as an isolation. And suddenly you find that you become an isolation hospital. And you also have the very people who are at risk are also there. Those with cancer, hypertension, non-communicable diseases, all bunched together. So, she took us through that stress. So it came with this attendant health, mental health issues, which was much later that it was acknowledged. And then she then illustrated that we're used to natural disasters, but the corona was a different type of disaster because it was on a personal level. And then it became obvious the health inequities between the halves, the West and in sub-Saharan Africa. Besides, we were all supposed to be dropping dead anyway. But somehow we're all standing, and so the issue for them is, why are we standing alive and not dead? So that was a big issue. So instead of coming to help us, they really making sure that we maybe fall down and die. But it didn't happen. So the point is that we, as sub-Saharan or underdeveloped or low middle income, whatever we call ourselves, it's up to us to really set the record straight and look into our own problems and not rely on the West to address our problems. So the global inequities, the socio-economic impact, the health effects, the containment, and then WHO, usually one of its best things that it comes up with a program to help countries deal with various components of the program. So COVID informal sector, and then you have to assess there was limited access to health. There was limited funding, and it put more pressure on the health system. The containment measures, the healthcare sector, really, the healthcare and the personnel, the impact of that. And then he illustrated the corona in the Ghana-China issue on evacuation of students from China to Ghana. And, so very quickly, concluding that the ability, a lot of things are beyond us. We can't control the dollar, but there are certain things that we can. That is ability to work with communities. The challenges, the real challenges of mental health, that makes its inability to function. And this is something that we can do as individuals, as communities, empowerment by community to lift each other up. Because if we lift each other up and we are positive, we can overcome a lot of adversity. So the importance of social and communities to salvage mental health, that is a major change to epidemics. That's one thing that individuals we can do. And then the second speaker, the costing and pricing of pandemics, give us some methods, types of costing, the theories, the cost topology, and then the broad category of how you cost pandemics, insurance, how to quantify it, societal responsibilities, and of course WHO comes in to provide standards for countries to manage their programs, and how much does a pandemic cost. And he took us through a summary of all the pandemics, and you could see that swine flu was 50 billion, Ebola was 50 billion, but the cost of coronavirus, and still counting, is even worse. The more importantly is our ability to understand and collect the right data. Because if we're not collecting the right data, we can't even assess the extent of health. So I like Dr. Akazili pointing us to suggested research areas where we can sit down and not quickly forget, but be able to provide the necessary research that will allow us to cost effectively impact on human, impact on the economy, and impact on the mental health. So I think with this broad summary, we thank both speakers for a wonderful evening. Thank you very much, audience.
Thank you very much, Emerita Prof, for those closing remarks and for giving us something to take back home. Please, let's give her a hand. Thank you. This brings us to the end of this evening's program. Tomorrow, Friday, is the last day of this year's Founders Week program. We have the Kwame Nkrumah Memorial Lecture tomorrow to be delivered by Emeritus Professor Ivan Adai-Mensah, a fellow of the Academy and a former Vice President for the Sciences section. He will speak on the topic, Educational Reforms in Ghana and their Impact on the Youth. I hope we'll see our youth back here tomorrow to listen to this very important lecture that has a lot of relevance for all of us. Before the lecture at 5:30, we have a pre-launch of our commemoration ceremony, and this ceremony is to recognize the contribution of some of the fellows of the Academy, people who have contributed significantly to the work, the growth, and the development of the Academy. And some sections of the building will be named after them. So we'll have that program at 5 p.m. to be followed by the lecture, the Kwame Nkrumah Memorial Lecture at 5:30 here at the auditorium. Please do join us. I'd like to end by acknowledging all of you here, especially the family and friends who are here to support the speakers, our fellows, both here and online. Thank you for joining us and for participating in every aspect of this evening's symposium. I'd like to thank our young friends, students from Presec to my right, and Accra Academy over there. Accra Academy were here with us yesterday and the day before. You've done very well. Let's give them a hand. And we are very happy that today we have Presec also joining us here this evening. A round of applause for them. Thank you very much. Now, there will be refreshment served in the foyer. So as you leave, please pick up some packed refreshment. Yeah. Refresh yourself before you leave. Thank you. Now, please stand while the chair and the speaker leave the room. Thank you.
what you're shown. Was that to do, you know? Bama, you know, yes, and why you know what you're shown. Kaya is a Kabaiki, and Ethiopia, that's what you're shown. Abaka, Batimo, yeah, for Kalacha, I get more, yeah, I'm a young thing. Abaka, Batimo, yeah, for Kalacha, I get more, yeah, I'm a young thing. I'm a Kamian Matu, I'm a Kaoyan Motu, I'm a Kaoyan Watumo.